Good evening, everybody. Welcome to the Suitcase Club, first Thursday in August. It's a special evening because we are not doing vaccines tonight. We're talking about malaria and malaria prophylaxis and malaria treatment. We've got a very special guest that's not with us around the table tonight. We've got Prof and Prof Bloomberg with us, so we've got at least two malaria heads with us. The Professor Karen Barnes is speaking to us from Cape Town tonight, so I'm very nervous about the technology, but Dr. Sam's managing that for us. So we're running from Travel Doctor in Johannesburg. We can move to the next, and that's from our premises in Rosebank in Joburg. Next one, and just a quick reminder that Suitcase Club is all about Geosentinel. That we'd love you to please send in your interesting travel-related infectious disease cases. We report that to Geosentinel, which is a JV between the ISTM and the CDC in Atlanta in the USA. There's an email address on the next slide, please, Sam.
Yes.
Okay, so you can either email geos@travel.corp.com or you can phone us if you've got a really interesting case like I'm going to tell you about in a moment. Next one, please, Sam. Just a quick reminder that for those of you that are out in the sticks, I've just spoken to somebody in Cape Town that counts as out in the sticks. Or if you can't find mefloquine, we've got some mefloquine available because mefloquine for pregnant women is still a Section 21 medicine and difficult to come by. Next one, please. This is just a reminder that if you miss this recording, if you have to go and bath the kids or wash the dishes, then you can see a recording of this important talk on YouTube, on our website. Thank you. Next one. I had a request from one of the SASTM Exco members, Dr. Salim Parker, just a reminder that Menkwatfi is being launched on the 13th of August. Those of you that are outside of Joburg don't have to feel bad because the seats are full anyway for the in-person launch, but you can still join for the virtual meeting. And that is on the 13th of August, an important new move in the prevention of meningococcal disease. Next one. Our sponsors tonight, for those of us that are here, and again, the online people are missing out, but thank you very much for the eats to Activo Health. They provide atopic proguanil as malaria prophylaxis, and they obviously have a vested interest in what we're going to talk about tonight, and Prof Barnes in particular. Next one, please. Real quick. So it's my pleasure to present Professor Karen Barnes. She's Professor of Clinical Pharmacology at the University of Cape Town. She's an internationally recognized malaria expert and WHO technical advisor, and she published more than 200 peer-reviewed publications, which is very, very impressive. Next one is over to Prof Barnes. And I hope we get all the technical bits correct.
Thanks, LB, for a generous introduction. I must admit that photograph was taken a long time ago, so you can all see how much I've aged since then. But it's a great privilege to have this conversation with you. And what I've been asked to talk about is how drug-resistant malaria in Africa changes our management of our patients and our travelers. Next slide, please. So one of the things that we need to be reminded of is that there are a lot of things going against malaria control in Africa at the moment. Climate change, population migration that's increased, health services are taking a strain. Funding has been stagnated for over 10 years, and the president, who LB doesn't like and I seriously dislike, has made the funding situation even worse recently. We have problems with a new vector mosquito that risks increasing transmission in urbanized areas where we could get a lot of cases more quickly than we currently get in rural areas where people are more spread out. And then, of course, you've likely have heard about insecticide resistance, diagnostic resistance, and drug resistance. And when LB was telling us about his case, One of the things that is a bit of a challenge is that the multi-species rapid tests are less sensitive than the falciparum tests, but the falciparum tests come with diagnostic resistance in some countries. And so the ability to get a smear done and to get PCR when we are unsure about the diagnosis makes an incredible difference. But my job here today with you is to focus on drug-resistant malaria in this perfect storm of problems that is seeing malaria increase across Africa, up to tenfold in Namibia and up to tenfold in Ethiopia, with limited data in some of the countries in between. Next slide, please. So I thought I'd focus on 3 questions. What do you need to know about drug resistance? Where has it been detected in Africa? And what does this mean for how we manage our patients? Next slide, please. So WHO has a relatively strict system of confirming or suspecting artemisinin resistance. And so in this map, the places in green have confirmed resistance in East Africa and the Horn of Africa, with suspected resistance in other parts of the Horn of Africa, including Ethiopia, and heading all the way down through Zambia and into Namibia. And because the artemisinins are the backbone of our treatments for severe malaria and uncomplicated malaria, this has been something we have been dreading since the problem started in Southeast Asia over 10 years ago. What's quite interesting is that it seems to have emerged independently. So it wasn't a traveler from Cambodia that introduced a resistant parasite. They've been independent emergences in different parts of Africa. And the clinical phenotype of this resistance is slow parasite clearance, which puts our treatments at risk. Next slide, please. One of the things that I find really interesting is looking at the evidence that we have along our borders. And so there is a part of the Caprivi Strip in Namibia and southern Zambia, where one of the WHO candidate mutations associated with artemisinin resistance has been detected. And in some of those places, the prevalence is over 40%. Another mutation that wasn't previously detected anywhere in the world associated with slow parasite clearance has recently been reported just as a preprint, but also presented at a meeting that the Gates Foundation held in Rwanda, showing you that in Zambia, in fact quite close to the place where Elby's patient came from, there is this new mutation with dramatically extended parasite clearance times, and again, prevalence is over 30%. But there are big holes in our knowledge, and you will see that right on that Caprivi Strip border, we have absolutely no idea what's happening in Botswana. We have absolutely no idea what's happening in Zambia. There's no evidence of resistance. There's just no evidence of anything. So we could be having cross-border spread of resistance. This is an area with very mobile and migrant populations. And yet we don't have that much information. I mentioned the sharp increase in malaria cases recently in northern Namibia. Botswana saw a similar increase in their number of cases, but they don't generate the data to know about how effective treatments are. So far, what we know from South Africa, from Mozambique, we're doing okay. Next slide, please. So why does this matter? It's been really hard to try and get ministers of health excited about a mutation in a Couch13 protein that isn't of immediate clinical relevance. And the three things that are important to understand is firstly how this can lead to treatment failure with the artemether-lumefantrine or whatever other artemisinin-based combination someone's using. And that is what we saw in Southeast Asia. And from this WHO map, you will see that countries had 1, then 2, then 3, then 4 ACTs failing at the same time. Luckily, this was in the middle of over 10 years ago, and the Global Fund was able to invest really heavily in this region and help them advance elimination. And so they're taking this problem away by eliminating malaria as far as they can. I think the whole region, excluding Myanmar, has only had 68,000 malaria cases in the last year. So they're making great progress towards elimination. But if something similar happens in Africa, where we have 95% of falciparum malaria cases, it's obviously going to be impossible. And this is happening at a time when the Global Fund, much as they recognize this problem, don't have the capacity to invest at the same level that they did in Southeast Asia. For those of you who like a bit of pharmacology just before you get your wine this evening, the reason why we worry is shown in this little figure on bottom left. And what happens is normally when our artemisinins are working really well, you see the number of parasites decreasing rapidly. And then in that little gray triangle, there are only a few parasites left for the lumefantrine or other partner drug to kill. And so the chances of the drug being effective has been really, really high. And that's why we've had effective treatment for over 20 years. What happens when parasite clearance slows as a result of artemisinin resistance is that that little gray triangle turns into a much bigger red triangle, and there are a lot more parasites left for the lumefantrine to kill. And with more and more pressure on the lumefantrine, you get more and more selection for resistance or tolerance, and therefore your risk of treatment failures increases. And that's what happened in Southeast Asia, and that's what we're worrying about happening here. Next slide, please. So we've only summarized this for East and Southern Africa, but these are assessments, therapeutic efficacy studies, or clinical trials looking at the efficacy of artemether-lumefantrine among parasites in those countries, or travelers returning to you from those countries. And what you will see is that in Uganda, in Kenya, in DRC, in Tanzania, and in places in Angola, the cure rate with artemether-lumefantrine is below the WHO's acceptable threshold of 90%. Equally worrying is that for many countries, we don't have recent data. In fact, for some countries, we don't have any data at all, like Botswana. Other countries like South Africa, Zimbabwe, we haven't had data for the last 9 or 10 years. And so we can't be sure that the places that haven't yet reported a problem don't have a problem, very similar to our problems with molecular surveillance. But because so many of the countries on our border have, well, at least Namibia and Zambia have artemisinin resistance, and we know that Angola and Tanzania are among the countries that have artemether-lumefantrine treatment failures that are unacceptably high, we need to be on the lookout for parasites that might not be responding as well to our treatment now as they have for the last couple of decades. Next slide, please. The next concern that we have is we know that artemisinin-resistant parasites are more likely to be transmitted than sensitive parasites. So this has a twofold effect. Firstly, the amount of malaria transmission can increase because you've got more of the gametocytes that transmit malaria. I'll come back to them a little bit later. And secondly, it becomes a vicious circle because you end up with more transmission of resistant than sensitive parasites. And as you see in this figure from Uganda, the prevalence of those mutations is increasing exponentially. And despite all the partial immunity that we should have in Uganda because it's a moderate to high transmission area, that rate of increase is as fast as it was in Southeast Asia, where people were mostly non-immune adults. Next slide, please. The last consequence, and this is a consequence we hope not to see. We hope to respond before we have an increase in malaria admissions for severe malaria and malaria-related deaths. We were pretty slow as a community in responding to chloroquine resistance, and we discovered too late that the places where we were having chloroquine resistance were having up to 6 or 9-fold increase in admissions and deaths. I've tried to illustrate this with a slightly complicated figure bottom left. And West Africa had much less chloroquine resistance than East and Southern Africa. And what you see in the figure on the left is that malaria deaths stayed pretty much the same in the West, but increased significantly from, I think, 7 to 12 per thousand between the 1980s and the 1990s. And it's accepted now that that was attributable to chloroquine resistance. It wasn't that the health system was crumbling, because the figure on the right shows the non-malaria deaths. And at exactly the same time that we saw an increase in malaria deaths, the deaths from other causes was going down significantly. And this is something we need to do everything we can to avoid repeating. Next slide, please. So it's pretty much a no-brainer that urgent action is needed to stop the spread and to prevent the impact of drug-resistant malaria on our populations. Next slide, please. So WHO releases a strategy. It has 4 pillars. I think you're not so much involved with the need for strengthening surveillance, although those knowledge gaps make it very difficult for you to give a traveler to DRC, someone going to work on a mine there, about what to do about malaria, or someone you're treating who's returning from DRC, because we don't have any data from that country. But we are going to focus on optimizing treatment and trying to limit its spread. And some of us have sheltered employment trying to do the research to answer the questions that remain to be addressed. Next slide, please. So in terms of optimizing malaria treatment, the good news is that severe malaria treatment does not need to change at all. If Albie's story had ended with this person being transferred to Cape Town or Johannesburg with severe malaria, we would still use injectable artesunate. It's by far the most effective option we have, and we just need to make sure that after giving the injectable artesunate for at least 3 doses in severe malaria, never fewer than 3 doses, and obviously continuing it until someone's features of severe malaria disappears, and then following it by a full course of an effective ACT for wherever that infection was acquired. So not just what's effective for South Africans in South Africa, but if they were coming from a place with artemether-lumefantrine failure, we would ideally need an alternative drug, which we will come back to later. Next slide, please. This is the fantastic study that was recently published that gave us that reassuring information. And so they studied children in the worst affected part of Uganda with the most artemisinin resistance. Half of the children had resistant infections, and they compared severe malaria outcomes in those with sensitive infections and resistant infections, and the outcomes were similar. In fact, the outcomes were slightly better in the people with resistant infections. And so this is the evidence that can reassure us that we don't need to treat severe malaria differently at all. Next slide, please. The next thing that we need to do is to ideally have an alternative treatment. If someone has failed treatment with artemether lumefantrine, say that the LB's patient had been treated with artemether lumefantrine in Liberia, I think it was, and now they've got malaria again and it's confirmed on a smear, you'd like to use something different. In South Africa, we're pretty stuck because we don't have anything different. And that's because our market is too small to interest a company in registering another alternative combination therapy. WHO recommends 6 options, even though we only have 1. And the most viable of those options I've left there in black, and I won't drag you through those names. Artesunate mefloquine, you all know mefloquine well from prophylaxis. It's not very well tolerated, and I don't think it's anything that would become widely used because of that. Artesunate sulfadoxine pyrimethamine, I think WHO should have taken it off their recommendation list at least 10 years ago because we have so much SP resistance. So those shouldn't be on your radar. But if some of you work in places where you have access to the other options, that's great. And I would recommend that we don't repeat treatment with the same drug when someone fails treatment or gets another infection soon thereafter. In South Africa, we've been trying very hard to register a second drug. And the good news is that thanks to a motivation from the National Department of Health, the SAPRA has agreed to fast track the review of dihydroartemisinin and piperacin to have it available as an alternative artemisinin-based combination in South Africa. So should we have lumefantrine resistance, should we have treatment failures, we should have an alternative treatment. It's only taken about 10 years to get someone keen to register a product, so we all hold thumbs that that SAPRA review happens quickly and happens with a positive outcome. It's WHO pre-qualified and registered by the EMA, so there are things in its favor, and we hold thumbs that probably by this time next year, that will be an option available to us. Next slide, please. With uncomplicated malaria, the key message at the moment in the global malaria community is called diversify ACTs. Stop having artemether lumefantrine being the drug that is bought 80% of the time. 80% of artemisinin combinations bought in Africa, for Africa, are one product. And that's just asking for drug resistance. Too much pressure on one drug. So we want to move away from that. Next slide, please. This is one where you can keep pushing your fingers down until we have all our pictures. Okay, this is just an introduction, and then I'll go through each of them slightly more slowly. So at the moment, we only have artemether lumefantrine in South Africa, and that is likely to stay the case at least until the end of this year. The one thing we can do is prolong the treatment course. So instead of an adult getting 4 tablets twice a day for 3 days, we give 4 tablets twice a day for 5 or even for 6 days. And that gets around the problem of having lumefantrine concentrations dropping below an effective concentration before all those parasites that are accumulated in artemisinin resistance, before they've all been killed. And that's the only option we have. And so I'm going to talk a little bit more about that as a short-term solution. We also like single low-dose primaquine. Not in Cape Town, not in Gauteng, but wherever you have local transmission of malaria, we do not want parasites to be transmitted to the next person, and we definitely don't want resistant parasites being transmitted onwards. So that's why single low-dose primaquine should be added to all treatments in endemic areas, unless you're dealing with an infant or a pregnant woman. In terms of diversifying ACTs, we basically could switch to one of the other options I've just listed, or you can have many of them available at the same time, like they have in Angola. Basically, anything that works and is on the WHO pre-qualification list is registered, and hopefully with market reshaping and changes to the pricing structure with more demand, alternatives will be used more and more, and that will take the pressure off artemether-lumefantrine. In the near future, probably 2027, 2028, the other options that will become available, we hope, are a triple combination where artemether-lumefantrine will be combined with amidiaquine, and that's a really smart combination because what makes parasites resistant to amidiaquine makes them more sensitive to lumefantrine and vice versa. So that should mitigate the risk of resistance. And then Novartis is developing a new product called ganaplacide-lumefantrine. And ganaplacide works even more quickly than the artemisinin, but it's not an artemisinin. So if we get high-level artemisinin resistance, this product will be great, provided lumefantrine is still working. If we keep putting all this pressure on lumefantrine, the worst-case scenario will be by the time we have these new drugs in 2028, maybe lumefantrine won't be working so well in Africa, which is why there's this big push to diversify away from artemether-lumefantrine. Not because it's a bad drug, but no drug should have to do 80% of the work. Next slide, please. So I think this is a moment where we can think as clinicians. We're treating patients, and we know that some people are coming from areas where there's drug resistance, like your patient in Zambia. A lot of people are coming from areas where we don't know what is happening in drug resistance, whether it's Botswana or South Africa or DRC. But we do know that some people are at much higher risk of failing treatment than others. And so if we don't want to give all patients 5 or 6 days of artemether-lumefantrine, which you could do with someone like me, you explain to me, because of drug resistance, we'd like you to take this drug for longer, it will reduce your chances of failing treatment, that will be easy. But at a national scale, it's quite a hard thing to persuade people and for ministries of health to buy double the treatment for everyone. So if we have to be selective, who would we choose? And it's probably not the easiest forum to ask you questions. So let's just go on to the answers. You're getting off light today. Be glad you're not my students. So people who vomit within an hour of treatment have an increased risk of failure. We should redose them. We should observe them for that period, the whole hour, and redose them. And if they vomit again, we need to give them injectable treatment. But if they manage to tolerate the next dose, but then they vomit more when they get home, they're a group that I watch out more carefully for. Some people are taking concomitant meds, whether it's rifampicin, carbamazepine, even St. John's wort, that are enzyme inducers that gobble up the lumefantrine, so they have subtherapeutic lumefantrine concentrations, and a much higher risk of treatment failure. Pregnant women have about half the drug concentrations of non-pregnant women. People who are large, and we all tend to define large as a weight larger than ourselves, but based on more evidence than that, they have shown quite clearly that people weighing above 65 kilograms have a slight increased risk of treatment failure, but it becomes significant when you're above 85 kilograms. And if you look at the average South African woman or Nigerian man, or most of us in between, a lot of us are over that weight. And it's not necessarily even obesity. Any of our rugby players would probably battle to come in under 85 kilograms. And most troublingly is looking at the graph at the bottom right. Southern African women, the rate of obesity prevalence is increasing more rapidly among Southern African women than any other group on earth. And so we have to be aware that the dose of artemether-lumefantrine, which was perfectly designed for the people that were studied on the border between Thailand and Myanmar, where the average adult, I think, weighs 42 kilograms, is not necessarily the perfect dose for the average or the above average South African. So that's another group that we should think about as considering giving a longer treatment course, because they're at higher risk of treatment failure. Young children, elderly patients, again, older than me makes you elderly, younger than me makes you young, but officially over 65 years. If you're immunocompromised or acutely malnourished, if you have a high parasite density to start with, you're at higher risk of treatment failure. And that's one of the disadvantages of rapid tests. I love rapid tests a bit. But if you're in a position to have a smear and you know someone's sitting with a high parasite density, that's worth paying attention to. They're at a higher risk of treatment failure, so they need to be monitored more closely. They also are at a higher risk of a post-treatment hemolysis that will often happen 2 or 3 weeks after a hyperparasitemic patient treated often for severe malaria is discharged. And if we don't follow up our patients, you can see really, really low hemoglobins. We had a 1-year-old child in Bloemfontein whose hemoglobin dropped to 4 grams per deciliter after being treated with injectable artesunate. So that's a group to watch out for. And anyone who's been treated recently for malaria, like Albie's patient, might well have been treated with the same drug that you're going to try, and they might well have a more resistant parasite. They might even be seeing a true treatment failure, and it's not a new infection, and that's why they need to be treated, I think, more carefully, monitored more closely. Consider giving them 5 or 6 days of treatment and do follow-up monitoring, if not possible physically, then at least telephonically, to make sure they're better. Next slide, please. So those at increased risk of treatment failure, apart from the increased duration of treatment, like everyone, we want them to take their treatment with some fat-containing food or drink. It doesn't need to be a lot. Half a cup of milk is enough to get better absorption of lumefantrine. Lumefantrine is a bit of a lousy formulation, and to tell a poverty-related disease community that they must take their treatment with fat when they're feeling nauseous, they've been vomiting, they have malaria, doesn't go down very well, understandably. But usually by day 2, the second and the third day of treatment, they should be feeling better, and that's when they should be able to take it with fat. Next slide, please. And consider the prolonged treatment course. It's recommended in the guidelines, the South African National Guidelines. Sorry, previous slide, please. And it's in the South African Medicines Formulary. So even though it's off-label use, it's not something that you would be considered medical malpractice to be increasing the treatment. It's rational. It's in WHO guidelines too. So it's I think something really worth paying attention to at a time when our hands are tied with only one treatment. This should be a good option. Next slide, please. Okay, this is a complicated graph, and I will try and go through it a little bit quickly. What it's trying to show us as policymakers is what's likely to happen to the number of treatment failures in thousands per month if we moved away from the status quo, which you can see blue left, which was artemether-lumefantrine as the only first-line treatment, and we changed to a longer duration of artemether-lumefantrine treatment, or we introduce artesunate amidiaquine or dihydroartemisinin and piperacin. Those were the options that they looked at. And it all makes perfect sense for everything until you get to the dihydroartemisinin and piperacin, which is in blue. And I will go back to this outlier shortly to explain why I think that is happening. But it does actually make sense. And I hope I'm not confusing you with this. Then the other thing that is recommended at the moment is that instead of everyone getting the same drug, rather try and diversify. So some people will get one drug, other people will get another drug, but in the parasite populations, they will end up being killed. And they've done modeling with different combinations, different ratios to try and work out what's best. That's not going to happen in South Africa, where we have too few patients and we don't need something that complicated. The last thing that they've looked at is combining more than 2 drugs. Like HIV has always been our guiding light, and we increased much longer after antiretrovirals were combining 3 or even 4 drugs. Now we finally moving from 2 and considering 3 drugs. And these triple combinations are considered the best solution in the longer term to prevent treatment failures because of that inverse resistance mechanism. Hopefully, if the one drug's not working, the other drug will work, even at a time when artemisinin are only partially effective. Next slide, please. So the first thing that you would think about with DP, much easier to remember than this ridiculously long name, DP compared to artemether-lumefantrine, is, well, maybe it's not a very effective drug to start with. And what these forest plots show you is that's definitely not the case. 78% fewer recurrent infections across all studies that have been done, all randomized controlled studies that have been done, and 75 fewer true treatment failures when it's exactly the same parasite that comes back into the second infection. So this is a highly effective treatment. That's not our problem. Next slide. This is the problem, gametocytes. Gametocytes are the stage of the parasite life cycle that have nothing to do with us getting sick, but they are the stage of the life cycle that infects a mosquito when they have a blood meal from one of us when we're sick with malaria, and they go on to bite someone else. So gametocytes are responsible for ongoing transmission of malaria. If you get treated with artemether-lumefantrine, then you have less than 20% chance of still carrying gametocytes 2 weeks after treatment. That chance is up to 8-fold higher if you get treated with DP. And that's because DP has a much lower dose of the artemisinin component than we get in artemether-lumefantrine. And this was found across a study with over 6,000 patients combining data from 23 different studies. And so I think this is pretty robust evidence. Some people say gametocytes are a surrogate marker of transmission, which they are. So they've also done experiments with mosquito feeding, and they prove the same thing. Next slide, please. So the take-home message is, even with artemether-lumefantrine, we recommend if you're in an endemic area or someone's going back to Zambia, we don't want them carrying parasites, let alone resistant parasites. So a single low dose of primaquine should be given to each and every one of those people, except pregnant women and infants. It's been a headache to roll this out because it's been on Section 21 because we haven't had a primaquine product registered. The good news is, as of July, we finally have primaquine registered for use in South Africa. So for all the treatments of radical cure of ovale and vivax infections, when you need to give primaquine for 7 days or 14 days, depending which dose you use, but WHO now recommends it can be given at a slightly higher dose over 7 days. But going back to falciparum malaria and drug resistance, a single dose is all that you need to reduce the risk of transmitting that infection. And this is a pretty picture basically trying to showing what I was trying to say earlier, is that our artemisinin combinations like artemether-lumefantrine are primarily killing the asexual blood stages, which are the stages that make us sick. But the gametocyte stages, especially the mature ones, are not killed by the artemisinins, and you need primaquine to get rid of those. So for any of you practicing in endemic areas or treating people going back to endemic areas, please add a single low dose of primaquine to advance our efforts at malaria elimination, but also to stop the spread of drug-resistant malaria. Next slide, please. So, you will be pleased to know we have reached my last slide. I highlighted during this the consequences of artemisinin resistance, and they are not minor, and they are something that we need to be alert to, especially because we know that resistance generally spreads from East Africa down into Southern Africa, and that prediction has been proven true so far. We worry about ACT partner drug resistance and reduced ACT efficacy. We worry about increased transmission and the extent to which artemisinin resistance might have contributed to the outbreaks in Namibia, Botswana, Ethiopia, and a few other places. And hopefully, if we all do things right, we won't see an increase in admissions and deaths. In terms of optimizing malaria treatment, severe malaria, treat the same. Uncomplicated malaria, in South Africa, we hope to diversify away from artemether-lumefantrine and have dihydroartemisinin and piperacin available in 2027. And we should, in the meantime, consider adding an extra few doses, particularly for those that are at increased risk of treatment failure. We're not going to go into the other options in a setting like ours. I've highlighted why we want to add primaquine to reduce transmission and the spread of resistance, and why that's even more important when we start using DP. And then LB said I might talk about chemoprophylaxis. So very shortly, the chemoprophylaxis stays exactly the same, but it's much, much more important. If you know a traveler is going to a place where they can pick up malaria that's more difficult to treat, then that's an extra good reason to not just do non-drug measures, but add chemoprophylaxis. Next slide, please. Back to you, Albie.
So if anyone wants to ask a question online, you can post it in the chat. I'm happy to read it out. Otherwise, you can unmute and ask a question. But I think so long, have we got any questions in the room?
Yeah, so thanks very much, Karen. It was excellent. Just from a practical point of view, what do you recommend when patients are treated with the dose of the normal one, artemether-lumefantrine, and they get better, and then a week or 2 weeks later, they get fever again? That's the common practical dilemma. What do you recommend?
Great question, always, Lucille. Thank you. So the first useful tip is that rapid tests are no use in that situation. When we kill a parasite, the antigens that remain behind are enough to make the test look positive. And so in that setting, you have to get a smear to know whether you're dealing with a flu or a true recurrence of malaria, which is why your patient had to go to a mission hospital to be able to do that. When we have no alternative, we are put in an awful situation. We had a patient at Groote Hospital that was a situation exactly like that, except he hadn't traveled back to an endemic area. So he had got malaria in Tanzania, come back to South Africa, got a full dose, full compliance with FAT of artemether-lumefantrine, and he arrived a month later with the same infection. And he didn't look confused to the eye, but his brother said he's not quite himself. So we thought that that was enough to give him injectable artesunate to get down the parasite load as much as we could before we were asking artemether-lumefantrine to mop up the infections. I don't think that's always justified. Off the record, so all of you with recorders on have to do something fancy to get it off the record, is like LB. we gave this patient a treatment dose of atovaquone proguanil because we didn't have any other option. And we thought this is perhaps the first resistant case this was before artemisinin resistance was reported in Africa, and we didn't want to risk undertreating that patient. There are also treatment doses of mefloquine. They're so poorly tolerated, I wouldn't recommend that option. And I really hope that within 6 months, they say, we might have dihydroartemisinin and piperacin as an alternative. Or if you're working in a country where you have access to give amidiaquine with your artemethyl-lumefantrine, that will be a good option. But at the moment, longer course or repeating the course, closer monitoring, or doing something off-label like atovaquone proguanil, I think are our only options.
So, but mostly it's patients who've not taken it with that. They often are more than 85 kilograms. So it's often worth just repeating the dose and at the same time thinking about resistance and giving it for longer.
Exactly.
And then contacting the lab who can give you a species, might be a relapse that you missed. And then drug resistance is done at the NICD, so you should contact
Yes,
the
but
laboratory.
it's not of immediate availability, so it's not practical to wait for that.
No, but you can start, to think about it.
Well, it can give you indication down the line, but you still have to manage it.
No, so we're going to increase the dose, the duration, make sure they have it with flat. Those are the usual reasons why they.
Yeah, and I think that patients tend to, when they
Non-possible.
fail treatment, they are more likely to be persuaded if we put enough time into it as to why they need the longer course, fat, etc.
If I could perhaps chip in here, so the case that actually stimulated me to ask you to talk about this was also done in Cape Town. I'm not sure whether Dr. Evert Bauer is online, but he's in Durbanville, and he saw an American missionary in his 70s from Zambia, whose wife knew everything about malaria. And I started off a little bit sort of skeptical about they know everything. But the story there was that he'd been treated, he had a full course of proper artemethyl-lumefantrine. It was a good drug, good source in Zambia. And then when they were visiting down in Cape Town, he got sick again. And he had a positive malaria smear, not just a rapid test. And this was a good 2 weeks or so after his initial treatment. And we suspected that there may be drug resistance. But that's before I knew that Zambia is a particular problem. So we tried to get blood to NICD in his case, but there was some miscommunication and reluctance somewhere between the patient and the doctor, Dr. Bauer, if you're there. And I think it's nice to talk about this because it stresses that if we do not report these cases, if we don't kick it up the food chain, if we don't go and look for it, we're going to miss it. And then we're going to be stuck one day and suddenly realize that I recall when you were saying about we were caught red-handed with a chloroquine resistance, but I remember there was this huge sudden change from Fancy Dara's treatment away, because when we actually went and looked in KwaZulu-Natal, there was 60-70% resistance, but that was first-line treatment at the time. And so I think it's important for everybody who sees people coming out of Africa to be aware of this, and then also to actually help us contribute to the research pool, so to speak, to know that this is happening. I also need to get a punch in again for your point about the importance of malaria prophylaxis. As you mentioned, it's just like rather get a pneumococcal vaccine than end up with a resistant pneumococ pneumonia in hospital. And similarly with this, don't struggle to treat malaria, especially if you're in a remote place, if you've been on prophylaxis. But what can we do? You mentioned the length of time it's taken to get Primaquine off Schedule 21 and on the shelves, and that it's going to take equally long to get, it's an impossible name, DP, dihydroartemisinin and piperacin. Got it. To
Well
get
done.
that registered, isn't there, and our colleagues here from Activo, I was talking about pediatric atopic proguanil. There is a company, their opposition, they've got the drug here, but not even the Prof of pediatrics in Wits knows that it's available in the market because it's so small. So the problem that you mentioned, if the market is too small, the gentleman also mentioned it, if the market is too small, it doesn't get driven. Isn't there an alternative to Section 21? Because Section 21 is hideously, unnecessarily expensive. But how do we get something like Mefloquine back on the shelves? Or is there an alternative to having a fully registered drug versus a Section 21 drug that gets imported by a specialist pharmaceutical company with huge markups to get these essential drugs to the public? And the last one is malaria statistics in this country. It's too hidden. It's impossible to find out what is happening in malaria now. And I will keep on standing on my soapbox about that for as long as I can. I've just had a request, why it's so important. The German embassy doctor who's now just left, his colleague might be online, asked the society, the Southern African Society of Travel Medicine, what is happening in malaria in South Africa now? Because they know about the floods, they know about the hot summer, they know about lots of water. And the German Society of Travel Medicine is considering changing the malaria map, the malaria period for which you should take malaria prophylaxis. Now, the Germans are probably doing it. I haven't had a face-to-face discussion, but they may be doing it because they're seeing more Germans going back home with malaria from South Africa at this time. And unless we can provide them with the data, we're going to end up bullying our tourism again because people don't want to come because there's malaria all year round in the Lowveld and in Kruger. So to get the stats out there, it's not a state secret, it's public property, and it's important to be able to tell people what's happening now.
Sure, LB. Those are a lot of questions and comments in one go. I'm going to start from the back. I will join you on your soapbox about access to data. I think it's ridiculous that we could have had Slim Karim on the news every night with the latest data on COVID, and we can't do the same for malaria, but it will inform policy and practice, and it should be routinely available. I think the South African Society of Travel Medicine could join with FIDSA and others involved in the field and say that it's not acceptable for a condition like malaria to not have that information available both in time and space. It doesn't help you to know that there are 5,700 cases last year. You want to know where they were, etc. So let's start a bit of a protest on that one. We need a Mandela power to the people there. Section 21. I don't want to bore everyone to tears because it's been a nightmare of my life. There is something called a special kind of Section 21 called for programmatic use when the request comes from the Department of Health, and then the reporting requirements are simplified. So we did get that for Primaquine, but it still requires endless nightmares for people involved. So we celebrate the fact that we now have a registered product, and I think that we need to reward that registration with demand and use. I think that it becomes a bit of a vicious circle. If people don't know that things have become available, they don't use them. And then, of course, that company is not going to want to register low demand products in the future.
Pediatric atopic proguanil.
Exactly.
It's actually out there, but it's not being prescribed by GPs and travel doctors and specialists because they don't know it's there.
Yeah, and that's why I celebrate a forum like this, because you make that information known, but we need to get messages more widely available. And I think that the issue with remaking maps is luckily the Department of Health has updated its map in 2025. The last one I think was 2018, 2019. So that has used relatively recent data, Lucille and I were involved with the America CDC, who also wanted to redraw our maps because they couldn't differentiate between imported and local transmission. So they'll probably soon have Cape Town as a malaria area. So I think we need to do our job better, disseminate it better, but not start allowing every country to have their own maps. And I'm afraid I've forgotten your question, if there was one about the case that you saw recently or you heard about from Helen Bauer in Cape Town.
Luckily, so you skirted very nicely around the large, more than 85 kilograms. But seeing that most of the people around the table are beyond 65, I can't remember what the other one was.
But I think that it is extending the duration of treatment is an easy thing to do. The other thing that we've got no excuse not doing is telling people what to expect. If our treatment is working, you should be feeling better by tomorrow, but that's not a reason to stop your treatment. You want to take it for the next however many days you decide that person needs. If you vomit after a dose, come back. I think a lot of things people write a script without making sure people know what to do, what to expect. But I would have no problems if I gave a third of my patients or half my patients even a longer treatment course with enough information. I think that that's a better option. A lot of people say, but they won't take it for 6 days. But even if they take it for 4 or 5 days, they're getting the benefit and no harm is done because they leave 4 tablets in the box. So I think that's something that as a short-term solution is our only option.
Prof, I just have a question online. So it's from Ahmed Hussein. He said, at what point should clinicians become concerned that standard artemisinin-based combination therapies are no longer effective, and what indicators should they monitor?
Because you'll see one treatment failure or you see one treatment success, like we had when Fansidar was thought to still be working, because people appear to get better and then they come back with a new infection. You need PCR to tell you if it's the treatment failure or not. So that's done at a national level, and we do molecular surveillance thanks to the NICD, and we try and do therapeutic efficacy studies, but because we have so few patients, that's quite difficult. And then we monitor the efficacy of drugs in the countries from whom we have most visitors. So for most of the country, that would be Mozambique and Gauteng, for instance. Surprisingly, in the Western Cape, most of our malaria comes from Namibia. So we need to bear in mind that when Namibia knows how effective its drugs are, we should be changing our recommendations here. And that's why we have to get ahead of the game with a new drug. But I think it's a hard job.
I think what they need
for an individual clinician.
There's a problem.
Yeah.
So most patients, get better by day 3. We don't repeat the tests. So, kind of how do you make that call? If they're still feeling off or weak at day 5, which is not totally abnormal. Temperature settle by day 3. So how do you make that call clinically? Because you're not doing parasite counts, you're not doing smears, and we shouldn't be.
So in the ideal world, if we can call our patients after 2 or 3 weeks and check that they're symptom-free and that they know to get back to us if their symptoms recur, and if they do, to repeat a smear, then for that particular patient that they've failed treatment. And then the discussion that we've been having about what else you can do apart from longer treatment, off-label use of atovaquone, proguanil, etc. So I think that routine monitoring is hard to ask for every single patient with uncomplicated malaria. But if they're high-risk patients, if they've been admitted with severe malaria, if they have high parasite density to start with, those are the people we can make the special effort for to make sure we give them a call, which is not a lot of work, 3 weeks later, and check they're doing okay. And 99% of the time, I'm sure they will be okay.
Prof, there's one more question. Since injectable artesunate remains effective for severe malaria, how long do we expect this to remain the case if resistance continues to spread?
Great question. I think that the evidence that we have currently looks like the way that the artemisinin work makes it unlikely that the situation will get worse. You get slower parasite clearance. It's only in the ring stage. Sorry, I'll get very boring, but I'll stop in a minute. It's only in the ring stage that parasite clearance is really slowed. The ring stage is not the stage that's responsible for severe malaria, and they think that there may be a fitness cost, that a resistant parasite is less viable than a sensitive parasite. And if that's the case, it's further reason that unless you hear anything further, assume that your injectable artesunate is the best option you have. We will soonish, have a new injectable non-artemisinin treatment, and my guess would be that that treatment will be available before the artemisinins fail for severe malaria.
Yeah.
Thank you very much, Prof. That was a very nice talk, and lots of stuff to think about, and I think a lot to be aware of. And I'm just going to say again that we might blur the sort of contentious bits about politics and so on, but for the rest, we're going to put the talk on our YouTube channel. So anybody who missed the talk or who would like to share it with some colleagues, which I think should be everybody, and we're going to send it out through SASTM again as well. This is really worthwhile for everybody, no matter where we practice, to know that they may be seeing return travelers that have got this problem. The easy one is the one that ends up in hospital, because our artesunate will still work, and it's the ID specialist problem. I just have to mention, so the ones that we're concerned about is the people that qualify as uncomplicated malaria, which if you're on a remote site, my rule was or is the paramedic or the doctor sees the patient every day, and preferably they do DOTS. It's direct observed treatment, because otherwise patients, even historically, stop taking the tablets when they feel better, or the Australians decide halfway down the week that they've got dengue because they know what dengue feels like because they had it in Kuala Lumpur or whatever. And then they stop treatment. And that was one of our few urgent medivacs over Christmas because it was incomplete treatment. So that had nothing to do with resistance. But I think the problem for seeing an uncomplicated patient in Johannesburg or Cape Town or Bloemfontein is if they don't warrant hospital admission and you're going to treat them as outpatients, you have to have daily contact to make sure that they're going better, and preferably see them. And then you can follow up with a full blood count. It's much easier than in the bush. I mean, just checking a urine dipstick and seeing, is there bilirubin, is there urobilinogen, is there more or less hemoglobin, something simple like that. It doesn't always have to cost a lot of money. And clinically seeing that the patient is getting better is very important in a case like this where you may be dealing with a treatment failure because of resistance. But thank you very, very much.
But thank you so much, Prof. What a lovely talk, and we'll send you the link once it's online.
Thank you.
Yeah. All right. Cheers, everybody.
Bye.